I'm Kristen Mallon, certified nurse midwife, here with Dr. Yakov Abdelik, high-risk perinatologist and MFM specialist. And this is True Birth.
We're going to talk about assisted vaginal delivery. We used to call it operative vaginal delivery, but then we were told that's like a...
That's scary.
Yeah, operative vaginal delivery.
Basically like a Halloween.
Right. People don't want to hear the word operate and vagina in the same sentence.
Definitely not. I want to think of an assistance in my vagina. Assisted vaginal delivery. Assistance. That sounds much better.
Okay. So we're going to talk about assisted vaginal delivery. And what we mean by that is vacuum, which is a instrument that's used to suction, a suction cup on the baby's head that's helped to bring the baby out, and forceps, which is these big, long metal tongs that go around the baby's head.
That look like salad blades, like you're going to toss salad.
Well, the way they crisscross, they look like, yeah.
Yeah, so like if you just had that in your house, you could put that in your kitchen and no one would be the wiser. They would be like, these belong here. If they were in the drawer that you open up. Why would anybody
have salad tongs that each weigh like 3 pounds? I mean, that would really be weird.
Let's say you're having a buffet.
You'd have to have a really big bowl of salad to use a forceps for salad tongs.
Okay, so we're talking about vacuum and we're talking about forceps. And this is part of the assisted vaginal delivery, because there's other things to assisted vaginal delivery, but these two specific things. So they sound really scary, and should I be afraid of them?
Not scary. They're very useful tools. Vacuum is used almost in every hospital every day. Forceps are not as common, especially these days, but they're also still somewhat common, and they're both very safe when used by the right person in the right setting. Okay,
so let's start with vacuum. So vacuum is a lot more common than forceps.
When would somebody need an assist on their vaginal delivery? I mean, what would be the situation you'd think that anybody would talk about using a vacuum or a forceps?
I mean, assistance sounds great in every situation, but let's say it's not going perfectly smoothly. You're getting to the point where maybe you labored a long time and now you're 10 centimeters dilated. You're either pushing a long time, longer than you thought that you were going to have to, maybe 2 hours if it's your second, third, fourth baby, or 3 hours or 4 hours if it's your first baby, or the baby's starting to get distressed from the labor itself.
I think you hit on a lot of very good points. So first of all, only talking about when you're fully dilated, that means you already finished dilating and you're pushing. This is not,
and you're 10
you can't
centimeters.
Assist somebody at 6 centimeters.
10 centimeters dilated.
Number two is they're used because you're running out of steam, the baby's not coming out, might be stuck, needs a little help, so you can't get the baby out and you need somebody to give you a little help, a little tug. And the last thing you mentioned was maybe it's not even a question of getting the baby out, but you don't want to wait because heart rate's becoming a big issue.
The baby's like, I can't tolerate this labor anymore.
And you want to just get this baby out and not wait another 20 minutes for mom to, push the baby out herself.
I always thought of vacuum as like Pareto's principle. You know, the economist who wrote that story about, or he had this kind of theory that like 20% of economies most economies are like run by 20% of GDP or 20% of your finances are what really push you over the edge into wealth. And that's kind of like vacuum. Like it's really the woman's doing 80% of the work and the vacuum is kind of doing the extra 20%.
Okay, I don't get that analogy at all. But
you never get my analogy.
That totally blew me away. So I always tell patients, I'm putting on this vacuum. I give them a demonstration. I say it's 80% you, 20% me, because I really don't know what the real number is. But I do know that I do want the patient realizing that her pushing is majorly important, probably more important than my pulling. And I don't want her to think, okay, now I'm just going to relax because I got somebody, who's going to help me get the baby out. So I want her to know that A, it's mostly her. B, I want her to own it because if this doesn't work, it's not, you have to know that you gave it 100%, not a half try. And that if it does work, which, usually it does, that the mother did really get the baby out. It wasn't like, she cheated. She really pushed the baby out.
Is it really the last step to C-section?
I would think that we don't use vacuum and definitely forceps just because. I think it's because a mother is exhausted and she can't push anymore, or the baby's not descending any further, it's kind of stuck in a certain place, or the heart rate's acting up. And I'd like to believe that every time I use a vacuum or forceps, I'm actually making a decision that either I have to do a C-section or I have to get this baby out with, or it's going to be assisted vaginal delivery.
So a lot of times when I counsel women in the office about the use of assistance in vaginal delivery, specifically with forceps or vacuum, I'll tell them that, you really have to decide, like, would you prefer a vacuum delivery or a C-section delivery? And kind of because most women, do you want vacuum or not? They're going to say, not, I don't want a vacuum. That sounds awful. But when you say vacuum or C-section, which is usually what it's come down to when you're using them.
That's a totally different question. It's a much more reasonable question than would you like a vacuum? Because we're doing a special today on vacuums. Let's talk about the difference between the modalities. A vacuum has been around for, I don't know, maybe 40 years, maybe. The first vacuum cup when I was a resident, and it makes me sound old, but there was a machine, they'd roll into the room, it had a tube, the tube was attached to the silicone big cup, rubber cup, and you put the rubber cup over the baby's head, and then you tell the nurse to turn on the machine, and it would sound, and then you would like, okay, I think I got a good connection now, and it was like really no way to really monitor how strong the connection was.
Wow, that sounds archaic.
You don't remember this?
Before my time.
After about 10 years, they invented the Kiwi, which I think most people are familiar with. It's a little plastic cup that's a hard cup, and you pump it up, a hand pump, so it's all one little unit device, and they're disposable, and you open, whoever invented the Kiwi is sitting on a beach somewhere sipping margaritas because it's
right next to the crypto guys.
Ubiquitous, and it's a very useful tool.
And it sounds really cute, Kiwi.
Kiwi, yes.
You went from this huge machine because when you think of vacuum, you think of like this very loud suction, something you plug into the wall, that's what you think of. But then when you actually see it in action, and it's actually small. So
it's very small. 5 centimeter plastic, hard plastic cup. It fits easily into the vaginal canal. You find it put on the baby's head. You pump up the vacuum, which means you basically empty the air between the suction cup and the head. And then you have a suction attachment. And it's a pretty strong attachment. And that together with the mother pushing, you many times can affect delivery.
And you can gauge how many millimeters of mercury, what the pressure.
It has a crude measurement device on it, like a green. Green is like you're in the safe zone. Red is like too much pressure. So you can pump it up till you get to the red zone, but you don't want to go into the red zone. It tends to work better when the baby doesn't have a lot of hair because it sticks to the head better.
Right, and not too wet.
Babies that have a lot of hair, it kind of pops off too easily. You want to use it within a certain realm of 2 or 3 pop-offs, and you want to be able to be somewhat safe that at some point it's not working, because a vacuum can cause damage to a baby if not used judiciously. It can cause separation of the scalp from the underlying bone, and then you get bleeding, and that could be a lot of blood to the point where the baby could even be danger to the baby's life. It's called a subgaleal hemorrhage, which is very scary, but very rare. And sometimes you get a cephalohematoma, which is a different type of bleeding under the scalp. It's a deeper bleed, but it's less dangerous because it's walled off, so the blood can't collect, and therefore your baby can't bleed as much. It's tamponaded more quickly. And sometimes you just get some skin abrasions
like a little hickey.
And that's kind of normal. So, but for the most part, it's rare to have a serious complication with the vacuum.
How often are you using vacuum? What % of the time are you using vacuum? 20% of the time?
I don't know. It's not 20%. It's less than that. But then again, we have a very high risk population.
Sorry, I meant first time mom. So of a first time mom, how often do you think that you're giving her some assistance?
Yeah, maybe
15%?
10 or 15% of the time, yeah.
Okay, so then of those 10 or 15%, it's less than 1% that are even going to have cephalohematoma.
Oh, cephalohematoma is not as bad as subgaleal hemorrhage, but yeah, it's very rare that we have a major problem. That anybody, especially if you use it, if you don't overly use it, if it doesn't work, if it doesn't stick to the head, it keeps popping off, you have to abandon the vacuum. And the lower the head is, the closer you are to delivery, the more likely you're going to be successful. So the lower the station the head is, the more likely you're going to be successful.
So the further the head is down in the pelvis, the more likely you'll be successful.
The learning curve with a vacuum is really small.
So you can learn it quickly.
Yes, because first of all, do you do vacuums? I know Hackensack has the rules.
I did until
Hackensack.
I don't know that we want anyone from Hackensack listening to this, but
yeah, but they don't let midwives use vacuums. But
they don't really let me do a lot of things. But
vacuums are very easy. You put it on the baby's head. You should know the position, but if you don't, it's probably not going to hurt anybody. So you should put it like closer to the posterior fontanelle and not as close to the anterior fontanelle, and like it should be closer to the occiput, and pump it up, and you kind of have to pull the downward traction. And yes, there's a learning curve, but it's a very quick learning curve. And if you are wrong on the position of the baby's head, it's most of the time no harm, no foul. It's not like forceps. Forceps, you better know what position the baby's head is in to put on the forceps.
I remember an OB told me that it takes 7 years to learn forceps.
That's cool.
I think that might be close to accurate.
I think it depends on how often you do them, right? But yeah,
you can learn vacuum in a year. You can learn vacuum in months.
Yeah, most OBs, almost every OB has some familiarity with the vacuum.
Yeah, most OBs will graduate from residency.
And we even see them use them. We use them in C-sections. People use them all the time, even in C-sections, to help get a baby out because, you know, you want to make a smaller incision. And we do that. You know, we try to make a small incision. And sometimes we can't squeeze the head and our hand out at the same time. And a vacuum is a nice little accessory that lets you grab the head without actually having your hand in there at the same time.
I think there's two cool things about vacuum too that it kind of make it a little bit less scary, is that sometimes it can just be used like a little bit, right? To just kind of give you another inch. Like you're not even really using it to deliver the baby fully, but you're just kind of like using it to bring the baby below the pubic bone or maybe redirect the head a little bit.
And then you take over.
And then you take it off and then you tell the woman to keep pushing. And I think that's kind of cool because it's not a lot of pressure. It's not a lot of exposure to the vacuum.
She still delivered herself.
And she still did everything. That's when like the vacuum does like 2% and the woman's doing 98%. And then the other time when I think it's really cool is that it can be used, I think for you, and you can speak more to this than me, obviously, but you can know the head's going to give or the head's not going to give. And I think that a vacuum can be used in that sense also, right? You know the head's going to come, like it's going to fit.
Or you mean it's going to pop off.
Or that the head's not going to fit and you have to do the section. Like it can kind of give you the answer to that question.
Right. Well, I think that question's on the table when you call for the vacuum because you're saying, this baby needs to come out and it's not. So give me a vacuum. And if that doesn't work, then you have your answer. You're saying that's the answer, that it doesn't fit. Time to do a C-section.
But I mean, sometimes it's easy to get that answer just with a little bit of use. Like you don't have to go through this huge, like momentous, like monstrous.
You're saying if there's it doesn't just drop at all. If the first attempt you get nowhere, you're like, okay, this is not working.
Like I've seen you do that in deliveries before where you use the vacuum very briefly and then something inside of you just know that this head's not coming.
Right, because I've been doing this long enough and I know that if I get zero descent with a head on a vacuum, we're right. Okay, so let's talk about forceps because that's has a much longer history, a much more colorful history, and I think it's fascinating. It's super cool.
agree with you. I think it's awesome.
So I like to say, and I believe that if somebody came up with forceps today, if it didn't exist in medicine, and Kristen Mallon, a certified nurse midwife, went to the FDA and said, "Hey,
I have this great idea.
Great idea. Look at these. They're stainless steel. They don't rust. Look how smooth they are. They articulate. You put this one on this side of the head. You put the other one on this side of the head. You
clamp down.
You squeeze them together so you got a good grip on the head.
And you just
pull the baby out. They would just think you had lost your mind. You have metal tongs that you invented to pull babies out of moms.
But thank God they discovered this, in the 1700s when they didn't have any other option.
17th century, maybe in the 17th century. So the original forceps were Chamberlain forceps. So Chamberlains were the man midwives to the royal family. They were as high as you go on the food chain.
Yeah, they were like ballers.
In England, they were the top obstetrics.
Yeah, in my mind, they just like lounged around all day, like ate, got gout, and then when someone went into labor, they were like famous or royal. They were like, okay, I gotta go into action. So how often did that really happen? That someone important went into labor?
It's a huge. They invented a huge tool that saved millions of women. Well, could have saved a lot more, but saved uncounted amounts of women. So they weren't that lazy and they were innovative and they came up with forceps, which was an amazing tool. So now let's understand something about old world medicine. Okay. So today, if you want to be a famous doctor, you come up with, studies and ideas, and then you publish them and you tell everybody, look what I found, right? I did the study and this medicine really helps, cure this, or I figured out a way, that to do something better, and you publish it, right? And you tell everybody. The old days, it was the exact opposite. If you knew something that was good,
you protected it.
You had to, because that was your thing. Right. That was made you special. You needed
people to need you.
If everybody knew what you knew, then why are you special? Why would somebody pay you? Everybody could do that.
Right.
So you would never publish anything. So the Chamberlains had the secret forceps for generations. At least
so they were
they handed it from father to son to father to son. And nobody was allowed to know about their secret forceps. Everybody knew they had a way to get stuck babies out, but nobody knew what it was. And they were so proprietary about it that it remained a family secret for like 200 years or maybe 150 years.
So I heard that they would blindfold the people in the room.
Oh, yeah. So if you read about it, you go on Wikipedia, or they would be called to come to the house of the lady so-and-so who's in labor
Marie Antoinette.
For 2 days. She probably was dead like several hundred years before this. And then they would come in their stagecoach and they would take this big, huge
box.
Yeah, not like
a trunk.
Trunk, right? Let's call it trunk. Two people grab each end of it, and they'd walk it in. The trunk was huge. I mean, you could have like a body in there.
You didn't think like people peeked,
and right, people
like the guys carrying
people
the
were
trunk?
staring. Everybody wanted to know what was in the trunk. And then they took the trunk into the room, and then they'd close the door. They throw everybody out of the room except for the woman, to blindfold the woman, and then they'd have somebody ringing a bell in the room so nobody could hear what's really going on. And they would make all types of unnecessary noises so that it sounded like some huge contraption. But meanwhile, in this big trunk was these like 1 foot forceps, salad tongs. Yeah, they had them like, with a bunch of bricks because they wanted it to look really heavy. So they had this heavy trunk, but it had this very small instrument in it, and that was their forceps. That was they would apply them, and they would grab the baby's head, and then they'd pull the baby out. And this was, saved many a woman. Some people say Chamberlains were great because they invented forceps, and other people said, well, they kept it to themselves, denying many women, life, because if they were to share their invention 100 years earlier with everybody else, how many more women could have benefited from it? And eventually, forceps got out, the secret got out, and it went through many iterations, and there are all types of forceps now. And there are forceps for women that are having their first baby, and women that have, if the head is tilted, and if the baby's posterior, and you could rotate with the forceps. You could have forceps for after coming head. So over hundreds of years, there were many, many different types of forceps. And I've even seen people collect them. They have all these old antique forceps that are like, they're really cool because, somebody invented these forceps in the 1800s or early 19th century, and now, it doesn't exist anymore, but it, had ivory handles, and they're pretty cool.
Well, what are the different types of forceps? So you mentioned, what are the different types of forceps used today?
So, I mean, we generally use, Simpsons or Tuckers or Lucarts, and each forceps has a specific different, they're all the same concept, but slightly different designs because they are useful in different types of women. The most common forceps are Simpson forceps. Those are generally for women having their first baby because the shanks. So the forceps have, I think, 4 major parts. There's the blade itself, the part that goes around the head.
Kind of like the spoon part.
Right. And that has 2 curves. It has a curve for the pelvis, so it curves upwards as the pelvis, and it has the inside curve that fits the head. So it has a curve to the head that's this nice round concave curve, and at the same time it curves upwards because it's supposed to fit into the pelvis correctly. Okay, so that's the blade, and the blade could be fenestrated, which means have a hole in the middle, or it could be solid. The solid ones don't grip as tight, but they don't leave as much marks. The ones that have a hole grip better. Sometimes you have pseudo-fenestrated, which means there's a small amount of rim. It's not a hole in the middle, but there's rim around it. And then the shanks, they could be separated or they could be overlapping. And then the lock, there's different types of locks. There's a sliding lock, and there's an English lock, and there's a German lock. Each lock has its own benefits. Some locks are better because it straightens the head out. Other locks, they are more stable so that it doesn't shift. And then there's a handle, and then the handle could even have traction, so you have a certain instrument you could add on to it so you can get a better pull. But yes, I mean, there's a lot of types of forceps, and yes, 7 years might be the right amount of time to study forceps because it isn't anywhere near as simple as vacuum. And now we can understand why there's not as many people using forceps.
So the Chamberlains should have just given their secret away because no one would have been able to learn it anyway.
Well, eventually it got out, and there was a time between, the Chamberlains keeping it a secret and the evolution of cesarean section where forceps were saving lives right and left.
And who do you think gave it away? It was like one of the sons was like, enough, we got to start sharing this with everyone.
No,
he had a conscience.
I think they actually found an old pair somewhere, like under the floorboards of an old chamber. I don't know, something crazy like that.
They
but eventually got out.
So what do you use forceps for? You use forceps to rotate the head, and you use forceps to deliver.
So there's rotational forceps, which is a big deal because sometimes the head's in a bad position and you can turn the head with the forceps. And more often not using them to get the baby out where you're pulling on the baby. Forceps are better than vacuum because you don't lose your grip. They don't pop off. They're better because you can get a head that's more difficult to get out, but they're more difficult to place, and they cause more damage. They cause more tearing in the woman, so that's bad. You have to know the position.
So they cause more tearing. Forceps cause more tearing in general than vacuum.
Right. Oh, for sure. Now, even a vacuum causes more tearing than a non-vacuum. Okay, because if a woman pushes a baby out, she's going to accommodate and stretch, and over time, even if that time is a half hour, an hour, her body has the ability to keep stretching until the baby fits out with a minimal amount of tearing. But once you put a vacuum on and you pull the baby out, then there goes all the stretching and all the accommodating, and you get ripping. So that is a problem with even a vacuum, except, if the head's already bulging out, probably not that much of a difference. Forceps are big blades, and when you're pulling the baby out, you're really fighting, hopefully, is not the body not wanting to come, it's the pelvis not wanting to open up enough to let the head out, let the baby out. So when you're pulling on forceps, you are really pulling a baby's head through a birth canal that is not wide enough, and when it becomes wide enough, it's because it ripped.
So not wide enough because of the musculature.
The soft tissue. If it's the bones, then the forceps.
You can't get the baby out, right? So it's really, so then that's why the soft tissue rips more, because that's really what's holding.
So
the baby
my
back.
theory, right? That today it's not the head that's holding the baby back.
It's the body.
It's much more often the body, and forceps are not going to be your friend. If a body is too big, if it's not the head and the body is too big to come out, then forceps is just going to get the head out and get you stuck at the body and give you a much higher chance of a shoulder dystocia.
So do you have a higher chance of shoulder dystocia with vacuum and forceps?
Well, tell the audience what a shoulder dystocia is.
So a shoulder dystocia is shoulder, meaning shoulder, and dystocia, meaning stuck or stopped, and when the shoulder gets stuck. So the head comes out, but the shoulder does not.
99% of the time, the baby's head's out, and the rest of the body is just a matter of a little maneuvering here and there to get the rest of the body out. But every once in a while, the head comes out, but the shoulders are wedged, and now the baby's not in, and it's not out, and it's in trouble. Why can't you just pull on the head then? Just grab the head and say, okay, head, let's go. Time to get out.
Because you can actually damage the nerves in the neck. So
yeah, so that's a really well-known problem. If you pull on a head of a baby that's stuck, you're going to stretch the brachial plexus, causing it to even tear. And then you got a permanent, lifelong brachial plexus injury where the baby cannot extend his arm or lift its arm over its head.
Paralysis.
And that's, some that obviously...
Even though 95% of brachial plexus injuries are semi-permanent or not permanent.
The ones that are only bruising or stretching, those come back. But if it rips, your baby's the baby's losing a lot of its
mobility in the arm.
Yeah, it's really bad. So you can't just pull on the head, and sometimes if you pull the baby's head out and then shoulder is stuck, you're even worse. Now, this is where I differ from conventional thinking. If you ask or Google why is it that shoulder dystocia is more common with a vacuum or a forceps. Why does assisted vaginal delivery lead to shoulder dystocia? The reason you'll get is because a baby should naturally turn and come out at an angle where the shoulders are not north-south, but a little bit to the oblique, right? We're a little bit northwest to southeast, kind of that angle, because it fits better. And when you put on a vacuum or a forceps, you don't allow this natural rotation to occur, and you're wedging the shoulder into the pelvis, and then the baby's getting stuck, and now you got a stuck baby.
So you're kind of jamming it.
That's the conventional thinking, okay? Because everybody agrees, and anybody who does vacuum or forceps knows that you have a higher chance of shoulder dystocia when you use a vacuum or forceps. And every study agrees with that, okay? So I don't think that's the reason, okay? For a few reasons. Number one is I've delivered a ton of babies with a bit shoulders north-south, and they come out just fine. And I'm sure you've seen that many times.
Yes.
They don't always come out oblique. Sometimes the shoulders at 12 o'clock, and it pops out just fine. And I've seen plenty of babies stuck
in the northwest, southeast.
Yeah, even in the oblique position. And I think what really is happening is you have a baby that's just too big, not the head. The body. The body is too big. And then you take these blades and you put them on the baby's head, right? Because the baby's like, the head is saying, I'm coming out, but the rest of his body won't follow me. And unfortunately for the spine and all the bones, I can't get out without the body following me, so I'm stuck here. But not me. Don't blame me. And then you say, well, we don't care. We're blaming you, head. So we put the forceps on the baby's head and we lock them and we got a good position, and we pull the head out. And all we're really doing is taking a body that doesn't fit and wedging it into even a tighter space.
Sounds awful.
Now the head is out, but the body is like squished in there and it's not coming. That's why I think we have a much higher incidence of shoulder dystocia with assisted vaginal delivery. The body was the problem all along and not the head. Right. So that's, and this has changed, because I will tell you that I think 100 years ago, the head was the vast majority of the problem, not the body. And now it's the opposite. This is my theory of why shoulder dystocia is more common in assisted vaginal deliveries. It's a real concern. If you don't know how to deal with shoulder dystocia, do not use vacuum and forceps.
Right.
I mean, that is really...
Do not attempt this at home.
I mean, we have a shoulder dystocia every month. I mean, we're always like,
at
okay.
Least.
How many times do you go, hey, Yaakov, it's a really big baby. She's pushing for a while. I'm smelling the shoulder. You tell me that all the time. Like, you don't mind just standing around, and then of course I stand there, nothing happens.
Yeah, that's my best scenario.
Only when I'm not standing right there.
That there's a big problem.
So you have to be ready to act. And shoulder dystocia is a drill. There are methods, there are maneuvers, there are tons written about it over the years. I have my go-to moves. Everybody has their go-to moves, getting the baby out safely. And you have to be very comfortable handling a shoulder dystocia, because if your first move is panic, everybody's in trouble.
I think you know this about me, but that's the one thing that I'll take anything. I'll take hemorrhaging, I'll take cord prolapse, I'll take abruption, I'll take fetal distress, but shoulder dystocia is my least favorite thing.
I would much rather deal with the shoulder dystocia than hemorrhage. I don't have any control over a hemorrhage.
Yeah. I feel like we have a lot of control over hemorrhage, and we have a lot of options, and we have a lot of...
Yeah, you try this and you try that. But I think with a shoulder dystocia, I think that I have enough tools to get the baby out safely. So shoulder dystocia is a scary thing. We should do a whole different episode, and we should dedicate it to shoulder dystocia.
I think that would be good.
And most women will only know the word shoulder dystocia because it happened to them, or else one of the things that they never heard of before.
Or they're friends with me and they've heard me talk about it.
Okay, so forceps have been medically classified into 3 levels, right? Low, mid, and high. High forceps are not done anymore. Everybody agrees that is way too dangerous. Meaning if the head is not engaged, do not put forceps on this baby's head. Meaning if the head is not even at 0 station, right? Mid forceps is if the head is somewhere between engaged and +2 station, which is actually starting to get pretty low, but without rotation. Mid forceps is 0 to +2 station or rotation. And outlet is if it's +2 station, which means the head is really low and you're not rotating. So once you rotate, you're already doing mid forceps.
Why wouldn't you use a vacuum then instead of low?
A vacuum's not rotating anything.
No, but why wouldn't you use a vacuum? So you're going to deliver the baby, it's low. You would never really use low forceps because why wouldn't you just use a vacuum?
Question about what the patient, a conversation with the patient. Sometimes you use a vacuum because the head is really low and you don't want to rip the mom off for no reason, and you're pretty sure the vacuum is going to do the job. And other times you're pretty sure the vacuum is not going to do the job, and this baby's going to be really hard to get out because it's posterior and
it has hair,
a hell lot of hair, and it's not that it's +2 and it's really kind of. So then you're going to say, okay, I don't, and you try not to use both. You don't want to, vacuum and forceps. It's probably
one or the other.
Yeah, you want to go with one or the other safer. So you want to choose the right modality, and that's a conversation with the mom.
Because each one has its own risks, so then you're just compounding the risk.
One is easier and less damaging and less effective. And the other one is harder, more skilled, more damaging, and more effective.
And when you say damaging, you mean to the mother.
Correct. If forceps are applied properly, almost babies will have some marks, sometimes even black and blue, sometimes some depression marks that will go away in a day or two. But the baby really should be totally fine. Nothing should be more than just a transient mark. It's the vaginal canal that takes the beating, and sometimes you can be sewing that up for a while, and you have 3rd and 4th degree lacerations, which is a whole. Oh my God, we're going to be doing podcasts forever. Well, every time I realize how many other things there are to talk about.
Yeah, it's endless.
I have a friend. I want to say this because this is a friend who's a lawyer, and he's actually a litigator, and like most litigators, he's pretentious, but more pretentious. He's actually a little arrogant.
Little hubris.
Yes, and he tells me I could learn any job in a week. I said, oh, so you could do my job in a week. If I followed you around for a week and you told me everything you were doing, I could do your job in a week.
That is a lot of hubris.
Isn't that? I'm like, I don't really think so, Jason. I think you would kill some people after a week.
I mean, I've been following you around for 10 years and I still can't do your job. So what does that say about me?
It says you're not a litigator. That's what it says about you.
Is his IQ that much above mine? That
he clearly thinks that there's no job that he cannot pick up in a week. So yeah, I should invite him. I was like, you know what? Come. By the way, I think you'd pass out after a day. Forget about following me. He wouldn't get through the first week of following me around. I think after one of our forceps deliveries, he would be on the floor.
And what would he do in the C-section? Like, where would he start?
He's like, yeah, how hard can it be? What's the big deal? I'm like, it takes months to learn muscle memory just to suture somebody correctly.
You know what that really means? It really means that we could learn his job.
In a week.
Oh,
but come on, you probably could, We probably could. I mean, I always thought that if I
litigator, 100%.
I joined a law firm, like a really good law firm, it would take 6 months before they fired me. Like, I think I could swing and BS for 6 months before they said, oh my God, We don't think this guy even went to law school.
Did you watch that movie or read the book, Catch Me If You Can?
Oh, yes.
Frank Abagnale. So he never went to law school. He took the bar and then he just he just became a lawyer. Like, he's just like, I'm a lawyer now and I'm a pilot and I'm like whatever else he was, a check casher.
He was a doctor also, but he didn't.
Oh, right. He was a doctor. Yeah.
Emergency room doctor.
That's kind of easy though. You're just like triage, nurse.
I read that book back in high school, so it's an old book.
Yeah.
Okay, so I think we covered assisted vaginal delivery.
Wait, I have a couple other questions about it. So, because I think it sounds a lot scarier than it really is, number one. And number two, a woman can choose forceps or C-section if she has a choice of forceps, that she doesn't have to go for forceps.
I don't think a woman should choose. I think our provider should tell her what's the most appropriate.
Well, a provider can make a recommendation, but she can always opt for C-section if forceps is too scary for her. That's what I'm saying.
You're saying she could opt out of assisted.
Right, she can opt out.
Assisted vaginal delivery should never be forced on
Exactly, that's what I'm saying, yeah. So she has the choice.
Right, but it shouldn't be scary to begin with. I think that a woman should realize that if she was smart and she chose a provider that's skilled and has the ability to get babies out, because anybody could do a C-section. Anybody. It's the simplest thing in the world, right? But getting
even your friend who's a litigator could do a C-section.
Okay, maybe not after a week, but yes, eventually he could do a C-section. But even if that's, even if a woman should know that if she chose a good doctor and she has faith in him or her and she knows that the person has good skills, then she should be comfortable that a vacuum or a forceps is not a scary, dangerous thing.
And to have these thoughts and these questions ahead of time. So you're not in the labor room when you're under duress and you've never heard of forceps before, or you didn't know it was an option with your provider and you've never heard of vacuum. And then when you're in the moment, it sounds totally freaky. But if you've thought about it ahead of time, do I want this or not? It's a little bit easier to kind of palate and swallow. And
one thing we didn't talk about, why forceps are disappearing.
For one, we said it takes 7 years to learn. So what schmuck is going to take 7 years to learn something that...
7 years or 7 days, depending on if you're a litigator.
Right. What's that guy's name? Daniel? What did you say? Jason.
Okay. No. So the reason why it's so hard to learn is because back in the day, right, in the 80s and the 90s, not even the 90s, but 70s and 60s, and definitely 40s and 50s, you didn't even ask permission, right? You had a woman in labor, you would take your student and you'd say, it was like...
It was a different culture.
And it was like, we're going to put forceps, she doesn't even need forceps, we're going to put it, I want to teach you, and then you would show your student how to put on forceps. I mean, and now we realize how unethical it is to do that, but that was the way medicine was practiced. People did not have to ask permission. They would they would teach, with the patients. So now we have informed consent, and we realize that the only way to have a patient participate in teaching is to say, okay, you don't need forceps, but I'd like to put them on because I have the student here who's trying to learn forceps. So it's okay if we put these big blades in your baby's head so we can pull the baby out instead of you just pushing the baby out and not having a big bad
Everyone just wants to sign up for that.
Nobody's in their right mind is going to sign up for that, right? So you can't teach forceps on somebody that doesn't need them, because why would they agree? Well, that would be really bad. And if you only teach forceps when you do need them, you have a bigger problem. It doesn't come up as often. And when it does come up, that's not the time to be teaching, because now you have a difficult delivery and you need an expert, not, somebody who's so it's much harder to give over the knowledge of forceps today because the opportunities are
dwindling.
And then the people that actually do them are, I don't know, 1 in 20, I'm just guessing, but maybe 1 in 20 doctors are still doing forceps. In some hospitals, there's no forceps. And if you only have 1 in 20 doctors still doing forceps...
I don't even think it's that high. I mean, how many doctors do we have where we work? 100? And how many of them do forceps? 3?
Maybe 5.
So yeah. I don't think it's 1 in 20.
Who's teaching, right? You have less teachers, you have less opportunities, you have many residents. So even if you do want to teach, right? If I did 100 forceps deliveries and I split those up with, I don't know, the 20 residents that are,
it's only 5 each.
Right. That's not enough. So I've been, working with Yoni, and he does forceps more and more often, because whenever we're together and it comes up, I make sure he gets involved with me, and he's getting more and more comfortable. He's on the 7-year plan.
And he's 5 years in, right?
And he's totally conquered breech, and he's totally conquered, twin vaginal delivery. He's completely comfortable with both of those, and forceps is still something that just takes more and more time to get used to. And Dr. Joel eventually, will get there, but it's it's like the opposite now. It's the opposite of what it used to be. Used to be that forceps, not the opposite, the full circle, right? They told you this theory that we started with a world where forceps were proprietary and secret and only given from father to son or from teacher to student. And then it went and became everybody was doing forceps. And now we're back to it's only given from teacher, right?
From master to student to student.
I can only train one person, and that person is somebody I'm always with. And that, it's impossible. Even if I'm motivated to teach the whole world forceps, I don't have the opportunity and I don't have the patience, and nobody's going to sign up for that.
So it's like the Japanese panda, and eventually it's going to become extinct.
Your analogies kill me. I'm trying to understand why the Japanese panda.
Because
that's an extinct animal.
Right, it's on its way.
Oh, so you're saying this is not an analogy. You're just saying this is like the Japanese panda, which is eventually we're never going to see anymore.
Right, eventually forceps. The knowledge of forceps is
because I'm trying to understand how that has to do with teachers. I give you way too much credit. I thought that on multiple levels.
Maybe you're just overthinking my analogies.
Clearly.
It's really just more I'll dumb them down for you.
Why did you say the dodo bird like it's gone forever?
Yes, but it's because it's not gone. It's on its way to going out.
That's true. It's not,
or like the white tiger. Is that a better analogy?
It's one of the great tools in obstetrics.
I agree with you.
I hope not.
So is there a solution? Or maybe you should open a school. Or maybe we should develop some sort of simulation model to actually teach residents.
I teach the residents. Actually, I did that last week. I taught residents on a dummy, simulated, not a stupid person, but actually
or maybe we need to do VR. Maybe some sort of VR software. We should write that.
It's still a little different. But okay, and the other thing is, so we talked about forceps. We talked about why they're harder to come by. It requires much more knowledge of anatomy. That's what I wanted to say. A good way to identify an expert person who delivers is somebody who's familiar and comfortable with forceps. Because if somebody's comfortable with forceps, they understand the pelvic anatomy.
I think that is a great point, what you just made. If you ask your physician, do you or does someone in your group do forceps? I think that's a really great way to know the expertise of any given obstetrician. So in sum, forceps are not as bad as they think. It's good to educate yourself about them and see if it's something that you may or may not want instead of a C-section.
And if you want to have like forceps at home and you want to actually feel them, you can buy them on eBay, because I do.
How much are they?
They're like really $30-$40, the used ones. I mean, but they're not used. They're stainless steel, so who cares if they're used? I mean, they're like diamonds. There's no such thing as a used diamond. A forceps is a piece of metal. A very shiny, well-polished piece of metal. And if they're made well, they'll last forever. And if you want to know what forceps are, you can just order on eBay because some hospital closed and they had like 100 forceps and somebody bought like a huge lot and they're like, I don't know what to do all these, let's just sell them on eBay. And it happens all the time. And I've bought, Piper forceps, which are for breech deliveries, for the aftercoming head. And I bought, for demonstration purposes. Sometimes, and they're really nice, very good forceps. And they're not that expensive if you buy them new. They're only a few $100, but the ones on eBay are really cheap.
Right. Or you could just go to our show notes and we'll include a whole bunch of photos and pictures of the different types.
Not only forceps, you have salad tongues. Combination.
I'm sure that's going to go over really well at my next dinner party.
People say, what are the things in the salad? They were recently in a woman's vagina, and now they're in your salad.
Don't worry, I sterilized them. And that wraps up our conversation this week about forceps and vacuum. If you have any comments or questions about any of the topics you heard this week, we'd love to hear from you. Reach out to us on our website at truebirthpodcast.com. And as always, remember to subscribe wherever you get your podcasts.